Thanks very much, Lenny, for the invitation to speak today. You've put together a wonderful conference, and I congratulate you for that. So what Lenny asked me to talk about was Pediatric ALL Trial Stratification, and really what do we do with all this information? So if you look, there are a variety of prognostic factors, at least in pediatric ALL, some of which we act upon and some of which we don't. But these include age and initial white blood cell count, which still remain among the strongest prognostic factors, and these are collectively used to define the so-called NCI criteria. Gender, which remains prognostic. If you have enough patients, you will see that females do better than males. All the reports that say gender is no longer a prognostic factor simply don't have the power to look at that, in my opinion. It's not a big prognostic factor, but it remains one. Race and ethnicity, immunophenotype, and I'll talk a bit about T-cell ALL as we go forward. And then early response remains one of the strongest, if not the single strongest, prognostic factor, and there are a variety of ways to measure that. And then the presence or absence of specific so-called sentinel chromosomal lesions. Charles Mulligan talked about this a bit yesterday, and these most likely are initiating events or very close to initiating events in leukemia development and are essentially always retained when relapse occurs. So which ones do we use in our treatment stratification? I've highlighted those in red. Age and white count. I lost the white count there. Immunophenotype, early response, MRD at the end of induction, and the sentinel chromosome translocations. And at the end, I'll come to the Philadelphia chromosome-like entity. So how do you use prognostic factors? And the main way that they're really used is to modulate treatment intensity. So one of the key factors, at least that we use, is whether to give a 3 or a 4 drug induction. I'll spend a little bit of time speaking with that. We now intensify therapy post-induction essentially for any patient with either a bad early response or a suboptimal early response or adverse genetic features. We've learned that T-cell ALL patients don't do well with low-intensity therapy that can cure a lot of B-lineage ALL patients. So all T-cell ALL patients are treated in our trials the same way we treat high-risk patients. And some of the terminology gets confusing because when we refer to high risk, we're generally talking about the NCI risk group. Many of the European groups use high risk to define patients who've either had an adverse early response or adverse genetics. So you have to be careful about the terminology and not compare between groups without knowing what comparisons you're making. Another way that prognostic factors can be used is to select poor risk patients to undergo stem cell transplant in first remission. We do a lot less of that than many groups do. And then one thing that is really becoming standard of care is to use prognostic factors to decide between transplant or chemotherapy in patients after relapse. So I want to talk a little bit about the standard versus high-risk therapy. And our therapies are fairly different for these two groups. So here I'm talking, the terminology I'm referring to is B-lineage ALL patients with NCI high risk, which is either age 10 years or older or white count 50,000 or above, or standard risk patients have age less than 10 years and a white count less than 50,000. So the induction therapies are different. We use a 4-week, the equivalent of the 1A in the BFM trials, of 3 drugs. So we don't use anthracyclines in patients who have NCI standard risk features during induction. Whereas the high-risk patients all receive 4 drugs, including an anthracycline. A big difference is the so-called consolidation or 1B phase. This has evolved in our high-risk trials to last about 8 weeks and be relatively myelosuppressive. In contrast, the standard risk patients receive essentially 4 weeks of what looks like maintenance therapy, so very different intensities there. We now have adopted, based on the randomized trial that Anjali mentioned, that Eric Larson ran, high-dose methotrexate, or the Protocol M for our high-risk patients. The standard risk patients receive an outpatient-based Capezi escalating IV methotrexate without rescue, without asparaginase. Delayed intensification is pretty much the same. It's not identical, but it's pretty much the same for the standard and high-risk patients. And maintenance is quite similar. And we do two things in maintenance. One is, or two differences. We do use monthly vincristine and prednisone pulses. That's not used universally. In fact, they're not used in Europe, at least continental Europe. In high-risk patients, these are prednisone pulses. In standard-risk patients, they're dexamethasone-based pulses. And we persist in treating boys for a year longer than girls. And I don't really think there's a lot of evidence to back that today, but we're really kind of stuck with our regimens that have used that for many years. So I want to talk about, in the next few slides, how our approach to standard risk came to be different and what data we have on the role of intensification for patients with standard risk features. So CCG 105 was conducted in the mid to late 1980s. David Tubergen was the study chair, and it asked a randomized question. So at that time, the basic children's cancer group, or CCG backbone, included induction, a CNS intensification phase, and maintenance. So there really was no post-induction intensification at all. Very good results had come out of the BFM early trials, and so this trial really was seeking to test BFM-based therapy and importantly try to find out what the key, if the BFM-based therapy was better, what were the key features that were better. So this trial was for so-called intermediate risk patients, which were more or less NCI standard risk patients, but this trial was conducted before the NCI standard and high risk were defined. So they're not exactly, but we can consider them that. And there were 4 arms. There was the standard CCG arm and 3 BFM-based arms. One was what we could call the full BFM, so it used the BFM Protocol 1 and Protocol 2. So Protocol 1 is a 4-drug induction and an intensive consolidation, and Protocol 2 is the delayed intensification. One arm used only the BFM Protocol 1 followed by CCG therapy, and another arm added the delayed intensification to the CCG therapy. And what you see, and particularly here's long-term results of this with 16-year event-free survival rates, I think there's 2 important points of this slide. The first is that all the BFM arms were more or less the same. So adding either the induction consolidation intensification or the delayed intensification was just as good as adding both. From this, CCG decided to go forward with the delayed intensification because that added the intensive therapy at a time when patients were already in remission. So this really is the basis for why we have continued now in the COG to use a very different induction and consolidation regimen in standard risk patients. The other thing to look at, and I do think this is important to think about, is the CCG arm clearly was worse, but it wasn't that much worse. If you look at these numbers, it was about 7 or 8% worse in 16-year event-free survival rates. So you can cure a lot of these patients with essentially induction, CNS intensification, and maintenance. And we really have to remember that as we try to think how to decrease the burden of therapy. If you could accurately figure out who these patients were, you could give them therapy that would have much less morbidity. So based on this, CCG and now COG moved forward with standard risk trials that all included delayed intensification, but they didn't have 1A, so they had a 3-drug induction that has now become dexamethasone-based, or 1B, the intensive consolidation phase. Now, recently we decided to revisit that question, thinking that those results I showed you are not, by contemporary standards, all that good. Event-free survival rates in the mid-60s long term. So we re-asked the question of whether intensive consolidation would improve outcome for NCI standard risk patients. And I don't want to go through all the details of this trial. It's been presented. Parts of it have been presented at ASH last year. Parts will be presented at ASH this year. But basically, it enrolled NCI standard risk patients. A lot of them, 5,300 of them, were enrolled over about a 6-year period. And patients were grouped into 3 groups: a low-risk group, an average-risk group, and a high-risk group. And it can get hard to remember all the definitions that we use. It's hard even for me at times to remember them, much less people who aren't familiar with them. But I think the simple way to remember them is low risk is good genetics and good response. Average risk is no good, no bad genetics and good response. And high risk is either bad response or bad genetics. That's the simple way to think of this. And I'm going to focus on this average risk group. And in this, we asked a question in this group. So first of all, looking at the overall outcomes for all 5,200 patients, we see a 5-year event-free survival rate of 89% and a 5-year overall survival rate of 96%. And when you break them down into those 3 groups, we can see that they layer as expected. So the standard risk low patients do better than the average patients, do better than the high risk patients. But one of the things I want to bring out in this slide is that about half of patients fall into this standard risk low category. And these patients had a 5-year CCR rate, so continuing remission from the end of induction, because the groups weren't defined until the end of induction, of 95%, and a 5-year overall survival rate of 99%. And this is a large group of patients. We got some PC Mac errors here in translation, but 1,857 patients. So one of the things to take out of this study is you can relatively simply define a large group of patients who are almost certain to be cured with low-intensity therapy. So the other main question, one of the big questions we asked is we revisited the question of whether an intensified consolidation would improve outcome, thinking that, number one, since the time that original CCG 105 study was conducted, we had improved, if you will, the consolidation by stretching it out to 8 weeks, adding the components of augmented therapy, which are additional doses of pegosparaginase and vincristine, and refined risk group stratification. So we thought this was an important question to revisit. So when you look at the randomization, patients, again, average risk, neutral genetics, and a good response. And I'm not going to talk about response now, but I'll talk a little bit about it in another talk this afternoon. But just in this trial, we used a minimal residual disease cutoff of less than 0.1%, or 10 to the minus 3 at end induction, which we now feel is not the optimal cutoff to use. So patients received 4 weeks of a 3-drug induction, dexamethasone, a single dose of pegosparaginase, and 4 weekly doses of vincristine. At the end of that, they were risk classified, and the average risk patients were randomized to receive either the standard or intensified consolidation, and then everything was the same after that. So this is the only difference between the 2 arms, but these regimens are fairly different. So the standard consolidation is 4 weeks of oral 6-mercaptopurine, 1 dose of vincristine, and weekly intrathecal therapy. In contrast, the intensified arm is the so-called augmented BFM1B regimen that includes cyclophosphamide, cytarabine, 6-MP, vincristine, pegosparaginase, and intrathecal therapy. So this is clearly a much more intensive regimen than this and carries with it increased toxicity, although in this age range, very little mortality actually occurs. And what we found is that the intensified consolidation did not improve outcome for these patients. So you can see the overall CCR rate for these patients was 89%, overall survival was 96%, and there's no statistically significant difference in terms of the patients who received the intensified versus the standard consolidation. There's a slight trend, but it doesn't hold up in overall survival. And if you can't see a real difference in 1,500 patients, then it's probably not clinically meaningful. So we saw that the intensified had an 89% 5-year CCR rate, and the standard regimen had an 88% 5-year CCR rate. So again, finding that intensified consolidation offered no benefit to these patients.
And one of the other things, if you start to use our more current thinking about risk stratification, we can see that there are so when you look at pediatric ALL, about 85% of patients have B precursor ALL. I should have said that early, that this is only talking about B precursor ALL patients. So about 85% have B precursor, and of those, 2/3 have standard risk, 1/3 has high risk. And if you look at the patients with modern, contemporary early response criteria, we see that we have groups with 5-year overall survival rates of 98 to 99% that are about half of pediatric ALL patients who can be almost certain to be cured with relatively non-intensive therapy. So I'm going to switch gears now and talk about immunophenotype and the prognostic significance of it. In the 1970s, the difference between B lineage, which was then called non-B, non-T, B precursor ALL and T ALL, became clear that one could identify this, initially using rosetting to sheep red blood cells. And at that time, it became very obvious that patients with T-cell ALL did much worse than those with B lineage ALL. Now, there are also associations with other known adverse risk factors, including older age, higher white count, the presence of CNS disease, and poor early response, but immunophenotype remained prognostic in multivariate analyses. And I think that's interesting, particularly for this audience, because if you look at all the adult ALL stratifications, T-ALL is a favorable prognostic factor. That's probably because B lineage ALL in adults, young adults, about a quarter of it is Philadelphia chromosome positive, and about a quarter, as Charles told you yesterday, is the Philadelphia chromosome like. So it's probably in adults that you have so many bad patients buried in the B group, and you don't have all the good patients you have in pediatrics with the high incidence of tel-AML1 fusion and hyperdiploidy. And one of the key lessons is that the pediatric patients with T-cell ALL don't do anywhere near as well when you use low-intensity regimens like the one I just talked about. And I think that that's the main difference. If you eliminate the good risk patients in the B lineage group, the outcomes are very similar. And these look at improvements over time. Again, large numbers of patients between the early 90s, early 2000 era. We see that B lineage patients improved outcome. We see a big jump for T-cell patients in the early 1990s, but not much difference after that. And then more recently, we looked at these data again. And when we first looked at these data, we were actually quite surprised by them, very pleasantly surprised. When we looked at the outcome of T lineage ALL, we saw, if this looks at 5-year overall survival rates, the risk of death was essentially cut in half between the late 2000 era and the early 2000 era. And when you look over time, you can see when you look in the 1990 to 94 era, there was a 14% difference in overall survival between B and T lineage. In the more recent era, that's down to less than 2%. So one of the big developments in pediatric leukemia over the past 2 decades has been the dramatic improvements in survival for T-cell ALL. And I'm going to briefly mention this trial, which we've just completed accrual to. So this was a study for newly diagnosed T-cell ALL patients. It asked 2 questions. One, we revisited the question of Capezi, methotrexate, asparaginase versus high-dose methotrexate, and the other patients were randomized to get or not get nelarabine. In this trial, almost all patients received cranial irradiation, and this was by far the largest T-cell ALL trial ever conducted. It enrolled about 1,900 patients with T-cell ALL or T-cell lymphoblastic lymphoma over a period of about 7 years. It completed accrual in July of this year. We opened a new trial last week, in fact, and have already enrolled our first patient this weekend. So this is our new T-cell ALL trial. We don't yet have any data on the outcome of these randomized questions. However, Brent Wood will present at ASH, which I'm not going to go into the details here, but you can see from the long title, and this was selected for a plenary session presentation. I'm sure some of you in the audience reviewed this. We thank you for that. But one of the most important findings was the outstanding outcome of T-cell ALL patients. And the other is we found absolutely no prognostic significance to the early T-cell precursor phenotype, or ETP. The outcome is exactly identical for ETP and non-ETP patients. And I think that that's very clinically important because there have been small studies published that suggested adverse outcomes for this group, and many people have acted on that and taken, as I was accused of saying, subjected patients to undergoing bone marrow transplantation based on that. But the difference is exactly the same, 87% 5-year event-free survival, 93% 5-year overall survival. And Brent will present that, and Stuart Winter and Kim Dunsmore were the co-chairs at ASH. So I'm going to switch gears in the last few minutes and talk a little bit about PH-like ALL, which you've heard a lot about. I'll probably skip some of the slides that are duplicative, but the question becomes, how do you use this in risk stratification? And Charles and I published an editorial last year. We irritated a few people by this sentence. I should make clear that I wrote it. Charles had nothing to do with that sentence. I think he told me I shouldn't write it, but I did. But I think one of the things we want to move beyond is simply using new data to stratify patients and deciding who gets a transplant or who doesn't get a transplant, or who gets more of certain chemotherapy agents and who doesn't. I think really our goal should be to say who gets therapy that's targeted at the underlying molecular lesions. And this is exemplified by results from our trial in Ph-positive ALL, originally published by Kirk Schultz in 2009, updated this year, showing 72% long-term disease-free survival in a small group of patients with chemotherapy plus Imatinib. And how do you apply this to other groups? And I think there are a number of principles that we should always think of. So if we can improve the outcome for high-risk patients if there's a driver molecular lesion that's fundamental to the disease process, that the leukemia is dependent upon the continued activity of this driver lesion. This is the concept of oncogene addiction, and that there's an effective targeted therapy that can be combined with chemotherapy. Perhaps sometime in the future, targeted therapy alone may be sufficient for acute leukemia, but today it's not. So today you can't think of treating these patients with targeted therapy only. It has to be combined with chemotherapy. And we started a project now about 8 years ago. I think we started this in 2006, really to try to identify the similar molecular lesions to the Philadelphia chromosome. And we've published a number of papers from this, and most of them are focused on this so-called pH-like subset that you've heard a good bit about. I'm not going to go into the details of it because you've heard them defined. But I think this slide, which is rather busy, tries to summarize a lot of these data. So first off, we see that patients with pH-like ALL do significantly worse than patients with non-pH-like ALL. This is from the COG-AALL 0232 study that Eric Larson chaired, and this is using the low-density array 8-gene card to identify these patients that you heard mentioned before. And particularly, we're focused on patients who have what we call ABL-class fusions. So these are fusions involving ABL1, ABL2, the CSF1 receptor, or PDGFR beta. Charles described this a bit yesterday, but the key factor is that the tyrosine kinase domain is maintained in the 3' region of the fusion gene, and the fusion is in frame. And when you look, these fusions essentially phenocopy BCR-ABL. So if you express them in factor-dependent cell lines, they allow cells to proliferate in the absence of growth factors. And if you treat them with the right tyrosine kinase inhibitor, in this case dasatinib, the ABL-class fusions all die, and the non-ABL-class fusions are unaffected by it. So this really suggests that if you could identify these patients and treat them with an appropriate ABL-specific TKI, be it Imatinib or dasatinib, that they should respond very well. And we have anecdotal case reports. This is one that Charles published a few years ago. We just got some updated information on this patient a few weeks ago. He continues to do well. This is a patient who failed to enter remission with 70% blasts at the end of 4 weeks, was discovered to have EBF1 PDGFR beta fusion, had Imatinib added to his chemotherapy, has continued to be treated with chemotherapy plus Imatinib, and he's doing great 2 years after the addition of that. And I think this paper you've seen referred to, but one of the things that's mentioned here, and the data are kind of buried in supplements, but a lot of these patients exist, and we, in this report, we didn't screen for them prospectively. We tested patients who there was some suspicion that they had an underlying molecular lesion, generally either an abnormality on cytogenetics or FISH, a very high white count, or a very poor response, or some combination of those. And of these, 24 of 28 cases we tested were pH-like, and 22 of them harbored a targetable kinase fusion involving either ABL1, ABL2, CRLF2, JAK2, or PDGFR beta. And 12 of the patients were treated with TKI therapy at the behest of the decision of their treating oncologist, and all responded very quickly to that. So based on these data, we're in the process of developing a clinical trial or amending a current clinical trial to include targeted therapy for these patients. Without going through all the details, basically we're going to screen all NCI high-risk patients, so somewhere around 700 patients a year, to identify those with the ABL-class fusions, and those patients will have dasatinib added to their chemotherapy at the end of the first month of induction therapy. Now, this has taken us a little longer than we thought, largely because of the complexity of the genomics. And this slide was up to date as of a few weeks ago, but I'm sure it's out of date now. Charles showed you an older version of this. But this shows you all the fusion partners. So we've identified 12 different ABL1 fusion partners, 3 ABL2 fusion partners, et cetera, JAK2, 13 different partners. So the molecular diagnostics are very complex. It's not like Philadelphia chromosome positive ALL where you just do PCR for BCR-ABL, you get the results and you move on. So this has challenged us to get the diagnostics correct. And I presented a lot of data from a lot of people, many but not all of whom are listed here on this slide. Thank you very much.